Welcome to the Full Partnership Conference, and it's great to see so many of you here today. And on behalf of Infoway, I want to welcome you to the 2014 Full Partnership Conference. I want to thank you for taking time out of your busy schedules to join us for the next couple of days. And especially I want to welcome everybody who's travelled here from outside of Toronto. Hope you enjoy your stay here. We're just near the Eaton Centre, although when I walked through it seemed that a lot of it's under construction, I think for the new Nordstroms that they're building. So that I don't think that's open yet, but there's certainly other opportunities to get some Christmas presents, I guess. So I'd like also to take a moment to thank our sponsors, and it wouldn't be possible to kind of have these conferences without support. First name sounds a bit familiar to me, Ag for Healthcare, then Acceleris, IBM, IMO, and Orion Health. And I'd like to thank you very much for helping us, and if we give everybody, could give them an applause. Great, so I'm very excited to have my first opportunity to kick off this conference, and in fact it's my first time attending it, so I'm really looking forward to the presentation discussions that we're going to have during today and tomorrow. And as you know, Accelerate, Connect, Share is our theme this year. Each of these words speaks to clinical interoperability, connecting systems, sharing patient health information, and accelerating progress. For more than a decade, the focus for digital health in Canada has been on capturing clinical information electronically at the point of service. We have made tremendous progress in this area, and we should be proud of what we've accomplished together. There's been significant growth in the adoption and use of digital health solutions, and as a result, we're now all able to quantify some of the benefits. In fact, we estimate the monetary value of these benefits at more than 10 billion over the past few years. Then there are also benefits that are harder to quantify. For example, the convenience of booking an appointment or consulting with a doctor online, the feeling of empowerment from a patient using a portal to check their own health information, the feeling of security from knowing that a pharmacist will be better able to spot potentially harmful drug interactions, and also the peace of mind from getting test results sooner, resulting in a quicker diagnosis and earlier treatment. We're continuing to work together so all Canadians will be able to experience these benefits, but the full value of digital health will be realised only when health information systems are connected, and authorised clinicians are able to easily access and share patient information. Then clinicians will be able to make better medical decisions and patient care will improve. We believe that now more than ever, the need to move forward on clinical interoperability with a sense of urgency. It's a massive task and a challenge to be sure, but we must work together in a partnership to make this happen. Over the next 2 days, you'll hear from a variety of speakers who are approaching clinical interoperability from different perspectives. You'll hear about a national interoperability strategy that's been developed with the clinical community and other partners and is now being implemented. You'll learn about opportunities to collaborate on interoperability. And you'll hear from clinicians, jurisdictions, and vendors about what they've learned from experiences with interoperability. There's never been a more critical time to have a national discussion about how we can accelerate clinical interoperability. So I hope you'll participate in this conference by sharing your views and experiences. And that's what the Partnership Conference is all about, coming together to share ideas about how we can work together to find solutions that will benefit everyone and their healthcare system. So thanks again for joining the conference. I hope you're going to enjoy learning from and sharing information with your colleagues over the next couple of days, and enjoy connecting with old and new colleagues as well, and I'm going to enjoy connecting with you as well. But in the spirit of sharing information and connecting with people, I'd like to encourage you to use social media to spread the word about what you hear at this conference. If you're on Twitter, feel free to tweet or post to your Facebook page or LinkedIn. We're also having a bit of a competition. We'd like to see you vote for your favourite speakers and sessions, the ones you would like us to feature in our upcoming webinar series. You can tweet your vote by using the @Infoway tag and hashtag #PartnershipConf. You'll find that the information on the screens throughout the conference and your votes will appear on a tweet wall during lunches and the breaks. You can also use the mobile app to rank your favorite sessions, and your download link is on the back of your badge. So while not as immediate, we'd like to have your feedback, of course, after the conference by completing a survey so we can improve what we do next year. Now it's my pleasure to introduce our first speaker, my colleague Trevor Hodge. Trevor is Executive Vice President at Infoway, in charge of our strategy area. He will get the conference going with an overview of an interoperability strategy that has been developed with input from many of our stakeholders, including a lot of you. So Trevor, also I don't want to put pressure on you, but I think you should know that I also recently got a Twitter handle, so I'll be joining in the voting for my favorite speakers as well. So anyway, with that, thanks very much, and Trevor, take it away.
So I'm going to speak a little bit about clinical interoperability, where we've, some of the ground we've covered over the last 12 months, certainly where we're at today, and give you some insights as to, I think, where we would like to see the agenda go over the next 2 or 3 years. And, you know, I'm going to start by saying, look, interoperability is not the sexiest topic within the eHealth agenda, but it's a very important one. It's a very important one. But let me just say, let's take a step back, and what's this agenda all about? It's about patient care. And really, that's the starting point for where we need to think about interoperability. It's improved patient care by clinicians who are able to obtain clinical value from health information. Health information that's shared through the interoperability of clinical solutions. And ideally, those clinical solutions are ones that are easy for them to use. So we have a key assumption here, that clinical interoperability is a critical component if we want to improve patient care through the sharing of health information. So assuming all that's good, what's the problem? From what we have seen, certainly the advanced use of these clinical solutions have been constrained by the approach that we've taken as a country to making clinical interoperability happen. And it's not just this country, by the way. It's pretty much every country in the world has been challenged by the interoperability agenda. And this sort of manifests itself in the clinical interoperability process being quite inefficient. So our feeling was, certainly 12, 18 months ago, that we need to accelerate the pace of clinical interoperability, and I think our feeling remains that way today. During 2013-14, we did a series of interviews. We did forums across the country, involved over 200 stakeholders, clinicians, eHealth program people, vendors, etc., and really asked them 3 questions around interoperability. What's working? What could we do better? And how could we accelerate the pace? So what is clinical interoperability? Let's start with that. So this is sort of the technical definition. It's when systems, devices can exchange and interpret shared data, and in this case, to assist clinicians. Clinicians providing care to their patients. So the example being the distribution of lab results from a lab to a physician's office. So that's how you would go, and if you were looking up a definition of interoperability, those are the kinds of words that you would see. But when we asked clinicians what's their definition of clinical interoperability, they said, well, interoperability for them is a user experience. And so that's the voice of clinicians when they talk about interoperability. It's a user experience. So when we asked, what's a good user experience? They said it's access to content with minimal disruption in workflow. Access to content with minimal disruption in workflow. So that's the clinician's voice of how they describe interoperability. And I'm going to keep coming back to the voice of clinicians and how they express what they need from interoperable solutions. So when we went a bit further and said, so what's been a good user experience? Not surprisingly, it was access to content with minimal disruption in workflow. So access to demographic data, just being able to look up a personal health number, depending on which jurisdiction you're in. Access to images and reports, often through a viewer of some kind. Access to lab results, access to discharge summaries, and even access to a more fulsome electronic health record in whole or in part. And typically that happened through a viewer. And often that viewer is in context with another clinical system, whether that be a hospital system or a physician office EMR, or in some cases, in some provinces, the pharmacists have access to the electronic health record as well. So that was all good. Then we said to them, okay, so what hasn't been a good user experience? And the example that came forward was the drug utilization review piece of medication management. Got access to content, in fact, way too much content in terms of the alerts, and actually it disrupted their workflow. So medication management and the use of certainly drug utilization review at an enterprise level has disrupted workflow, and that in turn, because it happens typically at the time of e-prescribing, has impacted the take-up of e-prescribing in Canada. So it's been slow. Provinces are still working on it and trying to figure it out and having a shot at it, but it has definitely impacted the diffusion of e-prescribing in Canada, in the community setting at least. Interestingly, the leaders in e-prescribing in Canada currently is Quebec. And what Quebec has done is actually not providing medication drug utilization review on an enterprise basis, but leaving the clinician to do that locally. And what you're seeing in Quebec is a more rapid uptake of e-prescribing. So where to next? What were the priorities, the ongoing priorities of clinicians around clinical data, getting access to it, and where interoperability may be required? So once clinicians get a taste of the electronic health record, whether it's in whole or in part, they quickly want more. And you'll see provinces like Manitoba or Saskatchewan or those kinds of provinces that now have some rich data sets in addition to the Albertas of the world who have been there for quite a while. The clinicians quickly want more clinical documents. So typically hospital clinical documents get added very, very quickly to the data sets that are in these electronic health records. And for those of you from Ontario, whether you're Southwest Ontario or certainly the GTA area, you're going to see that happen very quickly over the next, if you haven't already, over the next 12, 24 months. E-prescribing is still on the agenda, but as I said, it's remained a bit of a challenge. Medication reconciliation has actually probably gained a bit more momentum, one, because it's easier to do, but secondly, there's a driver there with accreditation. Remote patient monitoring, e-referral, and certainly diabetes management within the context of chronic disease management. Yet, as we say this, there's still a level of frustration, what we called angst, within the eHealth community. And it's because this interoperability, or achieving interoperability, is seen as an inefficient process that's taking too long. And this angst or frustration is not unique to Canada. You can go not too far south of here and you'll find exactly the same thing. In fact, the previous leader for the ONC in the US said the number one problem with their eHealth agenda in the US was interoperability. So from our analysis as an industry, the healthcare industry, whether it's here in Canada or whether it's globally, the awareness, the understanding of what are best practices end-to-end about doing interoperability just doesn't exist. There are pieces of best practice, but a fulsome, well-developed, and shared set of best practices across the continuum of interoperability doesn't exist globally today. And of course, this angst gets verbalized in many ways. And I don't think anyone escapes the verbalization, so I'll just go through some of these. But, you know, some people say, well, clinicians won't agree on common ways to capture data, so that's part of the problem. we've made interoperability too complex. Standards aren't, we have lots of standards, but they're not implementable as published. We have standards, but there's no standardization. HL7v3, HL7, everybody talks about HL7v3. Wholesale semantic interoperability. It's a nice dream, but it's not going to happen. On and on and on. Vendors are a problem. What I'm trying to get at is, as a community, we verbalize this angst in various ways. And really, these are symptoms of what exists as part of an inefficient process. So what we set out to do during last year and certainly earlier this year was to say, look, let's take a step back. Let's look at what we've done as a country. And we've done some good things in interoperability. Let's be clear on that. But we've also got some challenges in terms of the way we do it. But let's take a step back and rethink about how we might want to do clinical interoperability in the future. So when we asked stakeholders, how do we accelerate clinical interoperability, they really provided us with 5 perspectives. And that forms the basis of the strategy that we're going to present to you today and over the next couple of days. There is a clinical perspective, not a clinician perspective, but a clinical perspective. There's a specifications perspective, which I'll speak to, a product perspective. There's an implementation and operations perspective around the health information exchanges that have been set up across the country, and then a multi-stakeholder perspective. That includes clinicians, eHealth programs, vendors, and patients as well. And what I'm going to do is walk through these different perspectives and how we've translated that into a strategy. And really the path forward on that strategy has 5 steps. 1, unleash the clinical leadership. Let the voice of clinicians be heard in the interoperability agenda. It's not about moving data over the wire, it's about a good user experience. That's the voice that we need to bring forward. We need to realign our effort to focus on interoperability specifications, regardless of the standards that are used. And these are specifications that a developer can pick up and easily implement, i.e. to accelerate clinical interoperability. We want to use simple, open, technical solutions to enable interoperability. I'm going to talk more about this. So tools to document, edit, map, publish, and implement clinical interoperability in this country. We want to migrate many of our health information exchanges to a services model. So they're up, they're available, and vendors or clinicians can hook up to those health information exchanges at any time, assuming they meet the requirements of the health information exchange. As opposed to today, they're very much a project, and when the project's done, you wait for the next window to be able to hook up, if you hook up at all. And then, as we said, allow all stakeholders to have a voice. Not just clinicians, but eHealth programs, vendors, patients, etc. So let's just start with the multi-stakeholder view. Our strategy speaks to actively engaging all stakeholders, establishing new governance models, enabling an online environment for improved communication and collaboration, and start to establish some of those leading and best practices. And I'm going to give you a bit of a teaser today of what that can look like. A teaser because tomorrow morning you're going to see this in a lot more detail. So I'm really also here to promote the session at 9 a.m. tomorrow morning because it will go in a lot more detail about what I'm going to just give you a feel for as part of this presentation. So for governance, we're really looking at a structure that has sort of 4 pieces to it. A steering committee, an interoperability steering committee, what we're calling a set of communities to cater to the diverse interests of stakeholders, and I'm going to speak more to each of these. A set of working groups that are more project-focused with deliverables, as well as, obviously, engaging all the implementation projects across the country that are doing interoperability, so that, in fact, all those people are involved in the communities and working groups that we want to set up as part of this new governance structure. So let me talk a little bit more about each of those pieces. Our first step is the appointment of a steering committee, a clinical interoperability steering committee. The steering committee is to provide the direction and advice on the strategy and its implementation over the next period. The steering committee we co-chaired initially by Dr. Peter Rosas and myself, and will include a mix of eHealth people, clinicians, vendors, etc. Appointments to the steering committee are not permanent. These aren't lifetime appointments. So we're looking to engage all of you, the community, in taking part in these governance structures, whether it be steering committee, communities, working groups, as we go forward. So the steering committee itself, the members will have a 1, 2, or 3-year term, no more than 6 years, and the idea is to rotate people through the steering committee so that we can have an active and engaged community leading this agenda over time. This group will replace what we've traditionally known as the Standards Collaborative Strategic Committee, and at this time I'd like to formally recognize and thank the past co-chairs of that committee, Anne Vivian Beresford and Lynn Zucker, as well as all the other strategic committee, coordinating committees that have contributed to a lot to furthering the standards and interoperability agenda in this country over the last decade. The second piece, and I think is exciting for everybody, is that we want you to be able to set up communities of interest, things that may interest you. So these are gatherings of people that may have a common or a specific interest. They could be domain-based, so it could be around medication management, just as an example. They could be professionally based. Could be nurses or physicians or pharmacists, for example, or whatever topic you really want to create a community, a discussion around. In addition, we will set up working groups, and these may not be working groups that are sponsored by Infoway. They may be your own working groups that are not sponsored by Infoway. And these working groups would be to support the steering committee on the one hand, or the communities on the other hand. But very much project, deliverable based, to support the discussion that may happen within those communities. And then lastly, but most importantly, is to connect the implementation projects, the places where interoperability is happening on the ground in Canada, and get the people that are doing those projects involved not just in working groups, but also in these broader discussions, the communities and the steering committee that we're using to govern interoperability on the go forward. So that's governance as we're proposing it today. To support that whole governance structure, we are wanting to engage a large number of people. We want them to get involved, and obviously we need a robust online environment for that to happen. And what we've tried to do here is model this on what the telecommunications industry uses globally. So we'll be putting up an online platform, and you're going to see that actually tomorrow morning as you go to your session. It's up in a beta form right now and existing, and so you can see how communities can get created, how working groups get created, how you participate in those kinds of things online. Include things like news, obviously collaboration for those different groups I just talked about, plus a whole bunch of online resources, standards, specifications, clinical requirements, plus a lot of the tools that developers need to do interoperability, as well as information about upcoming events, training, whether it's online or offline, etc. So again, a very rich, fulsome online environment that you can use, whether it's creating your own community or part of a working group or being part of a community, and participate to the degree that you can in this interoperability agenda going forward. The second part of the strategy that I now want to cover is around unleashing the clinical leadership. And the first piece was, how do we create a sense of urgency to do things differently? And this is really the most challenging step of all, because it's so easy for us just to fall back, as a country, to fall back and just maintain the status quo. Because there's some things that we need to change here if we want to accelerate this agenda, if we want to do it differently, if we want to do it more effectively. We obviously need to enhance the clinical role in interoperability, getting more and more clinical leaders involved. And you'll certainly see that, certainly from us, as we move forward. We want to establish not only the clinical vision around clinical interoperability, but also what are the next priorities? Is it those things I had on the list, more clinical documents? Is it e-prescribing? Is it medication management? Is it remote patient monitoring and so on? What are those clinical priorities for interoperability that everyone can benefit from and share from, whether you're a clinician, you're developing standards or specifications, or you're a developer? What are the next pieces of the puzzle that we need to focus on as a country? Clinicians want to be educated about interoperability. So how do we do that in an effective way? How do we help develop the capacity of these different groups? Physicians, nurses, pharmacists, and so on. And then, certainly from our perspective, a piece of what we've done previously that we think has been missing, and missing in most countries, is defining the common clinical requirements that need to be shared. What is the voice of clinicians around interoperability that needs to be shared? The start of the continuity, of creating a continuity from clinician requirements through to code that we need to develop for this country. So talking about sort of moving along this continuum of clinical requirements to code, the next piece is around specifications. Another critical component that we felt has been not well developed in this country. We've certainly put a lot of effort into standards, and that's been great, and we still need those. But on the go forward, we also need to take those standards and make them implementable, and what we're calling specifications. So certainly what we heard was, look, we need to raise awareness and understanding about what interoperability specifications are. And you'll notice that word, the recipe. So we've talked about standards being an ingredient, but we need to create the recipes that developers can pick up and easily implement. We need to create those common recipes, whether they're for medication reconciliation or e-prescribing or whatever they may be. We need to create some common recipes that developers can easily pick up and not have to reinvent that wheel over and over. Obviously, we need to continue to use standards, but use them appropriately. And I think, the storyline you'll certainly start to hear from us is data standardization is very important, and we will continue to push that agenda. But on the technical side, we're looking more for harmonization. We don't really care so much about whether it's V2, V3, CDA, FHIR, name it, XML. I don't really care how the data gets transported. So the focus will be very much on data standardization and really making it easy for product vendors and others to use a multiple set of technical standards. Obviously need to realign the funding and incentives for interoperability so that we're not just stuck in the status quo. We need to create some movement. The next one was actually a bit of an Ontario issue, data sharing agreements. And what can we do to start to free up what are starting to become rich and deep data assets within Ontario and make that data move around Ontario a lot easier than what appears to be today. So, and we've certainly, good fortune of ours is the new Deputy Minister for Ontario happens to be on our board. And we did this presentation to him, and the first thing he said, "What are you telling me, Trevor? We need new legislation?" I said, well, short answer, yes. So, what I'm getting at is there is a time probably to have that discussion. And again, educate all stakeholders about how to improve our interoperability effort, and in this particular case around what are specifications, how do specifications get developed, and how do we move them forward. So speaking of specifications, I'm going to give you, again, a teaser on what we've done thus far, all the detail to come tomorrow. And I'm going to use an example from medication reconciliation. Why? Because it's relatively easy to do. So medication reconciliation could be carried out in different care settings. It could be in a GP's office, it could be in an ER, it could be within a hospital at the time of admission or discharge. What we're trying to say or suggest is that there could be a number of different types of clinicians involved in medication reconciliation depending on where the care setting is. But the key is to have clinicians describe in their own voice their needs for interoperability related to medication reconciliation, what we've called clinical requirements. And the reason we're highlighting this is because we don't see a lot of clinician voice words in clinical requirements today. However, gathering clinical requirements, having clinicians express their clinical requirements cannot be done in the absence of sort of the architectural environment within which they live. So you've still got to take into account all the systems that are in place in the environment that you're looking at to do medication reconciliation. Otherwise, the clinical requirements and the expectations created from that just won't be able to be met, because you'll start to greenfield solutions, but you're constrained by the systems environment within which you live. And we've got to be very careful that we just don't go out and do clinical requirements, get clinicians' voice, create a whole set of expectations that can't be met because you also have a clinical environment of systems, a whole set of systems that just don't quite allow that. So the architectural context sort of guides and constrains the clinical requirements that need to get developed. The clinical requirements can be then translated into what we've called a technical specification or an implementable specification. In this case, it would be around getting a medication profile for medication reconciliation, so that you've got, at least in an electronic form, the best possible medication history, even though the clinician may be also asking verbally and entering into a hospital system, for example, what the patient may be telling them as well. So interestingly, the Get Medication profile specification not only serves medication reconciliation, but that same specification could also be used for e-prescribing, can also be used for e-referral, can also be used for just viewing an electronic health record. So what I'm trying to get at is we just by taking one particular clinical need around medication reconciliation, we can create a specification that can be reused in multiple clinical scenarios. And of course, when you take the medication reconciliation clinical requirements and the implementable specs, and those become part of a solution, interoperable solution design that you see at the bottom gets translated into code that allows EMRs, hospital systems, community pharmacies, and others to interact either with themselves or, in most provinces, with a provincial drug information system. So what does a clinical requirement look like? How would clinicians describe their needs? And as I said, all I'm going to give you today is the teaser. You should come tomorrow and you'll clearly see how the set of questions that clinicians have provided to us, the line of inquiry that needs to happen for them to have their voice. So certainly there's a clinical context, and the systems context within which the clinicians live in their particular care setting. There's a set of observations about how clinicians describe their needs in their words. And then there's examples of, okay, who else has done this and what did they learn from this particular scenario. And lastly, clinicians want to see this as a mock-up. Why? Because they want access to content, minimal disruption, and workflow. They don't just want the IT community to just go away and make that interoperability happen for them. They actually want to see the data and how it's going to be presented back to them in a series of mock-ups, and then iterate those mock-ups. So it's our intent to start to develop these clinical requirements and make those available online so that people can be shared. So we're not reinventing the wheel. And certainly what clinicians say to us is, look, every new project we're engaged and we seem like we're reinventing the same wheel. Can we get these shared? Not to say we can't tweak them and modify them, make them more local for ourselves, but there's got to be a base of knowledge there that should be easy to pick up and use across the country. Implementable specifications. So in a similar fashion, the Get Medication profile specification provides the software developer with what he or she needs to successfully orchestrate clinical interoperability. And really what we're trying to get at is, what are the specifications that a developer should expect to see, the things that they're actually seeing in other industries and using in other industries, but they're not available to them in the healthcare industry today. So, in short, there's a business interoperability piece that includes a short use case, business rules, as well as some hints for information interoperability. It will include a simple system interaction diagram, as well as detailed clinical information that's being transferred, any terminologies, coding schemes, etc. For technical interoperability, there's a set of APIs, some sample code, sample messages that a developer can easily access and use in their final solution. This is geared to the developer. And any other guidance that they may need around security or transport management, etc. Bottom line is, it doesn't really matter whether the developer is using HL7 v2, v3, CDA, FAR, it doesn't matter, or any other method of transport. The base specification about getting medication profile can remain the same. And our focus, of course, is to try and standardize the data within that medication profile rather than worry about how the data is moved around. Again, the idea will be to create implementable specifications that can be made available and shared online. Things that developers can easily pick up and use. And we have a working mock-up of a specification today, which you'll see tomorrow. And I think from a developer's point of view, you'll be pretty excited about what you'll see. There'll be things that you're used to seeing in other industries. We're not saying this is done. All we're saying is this is the start. And as a developer community, now's the opportunity for you to take this and iterate it and make it better and better going forward. Using simple, open, technical solutions to enable interoperability. First one we have there is harvest the low-hanging fruit, single sign-on context management. Not the most elegant way of doing interoperability, but it does enable access to content, minimal disruption and workflow very quickly, get a large number of users getting the benefit of the data assets, even though that may not be the long-term solution for what you're looking for. So when we look across the country, the Albertas of the world have used single sign-on context management to get what is now over 45,000 users online using their electronic health record. Physicians, pharmacists, nurses, hospitals, pharmacies, GP offices, etc. A real success story, not only here in Canada, but when you look around the world. It's our intent to, and we've been in discussion with the jurisdictions, to accelerate the use of context management as not the long-term vision of what we want to do here, but certainly to get more users accessing and getting value from the data assets that exist today. And you certainly will start to see that in Ontario here. Supporting the rapid development of solutions. So again, provide an environment where developers can locate, download the tools that they need to do interoperability. Enable solution portability across the country so that vendors can easily move from one province to another and implement their solutions and not be constrained by intense localization that requires them to redevelop from scratch again. And then use national testing and certification where possible. We've just completed a review with, in collaboration with ITAC Health, and have an agreement in principle with some of the jurisdictions and the clinicians that we had involved around certainly getting some national privacy security standards testing done that should be accepted in every jurisdiction so that vendors don't have to go back and repeat that every time they go to a new jurisdiction. So you'll start to see and certainly hear some of that. So just to give you a sense of the tools, and I'm not trying to say these are all the tools, but give you a sense of tools, to edit, map, publish, implement interoperability across the country. Some of these are tools that Infoway's created. Some are tools that other organizations in Canada have created, like UHN or Mohawk College or Quebec has created. And then some of these tools are actually just available globally. Our intent is, if we don't own and can provide those tools online, is to provide access to all those tools so that people know what is available globally here today to help accelerate the pace of interoperability. And then lastly, in terms of the strategy, how do we migrate our health information exchanges to a services model away from these sort of project-based models that we've seen? And as we indicated, we need to create some best practices for health information exchanges. There isn't any that exist published today globally. We see some examples of best practice within Canada, but not across the spectrum of what it requires to implement and operate a health information exchange. So not only develop the best practices, but actually demonstrate those best practices with some health information exchanges in the country. And one of the issues that they're facing is operations funding, the money to sustain these health information exchanges, to start to evaluate what that takes and create again a reference model for operations funding for the health information exchanges. And we currently have in the process of bringing in a consulting firm to help us develop the best practice, and then, as I indicated, we will then start to invest in an end-to-end demonstration of that within the country. So I don't have a lot of time for questions at the end, given the time, but I've done this presentation, just a couple of trial runs prior to today, and these were some of the questions that came back to us. So I'll just share those with you as an absence of a Q&A session. And the first one, and I'm sure he wouldn't be ashamed of the fact that he asked the question, came from Mike Newsbaum. And he said to me, this feels like a made in Canada strategy. Is it a made in Canada strategy? And I think, the sort of corollary to that is, have you considered what the rest of the world's doing, or are we being sort of myopic here? And it's a good question. Well, the short answer is yes, it is made in Canada. That's because we are in Canada, which is a good thing, and we're all proud of that. And it's certainly been tailored to the health industry in Canada. But let me say it's been drawn on what we have seen as best practices in other industries. When I talk about specifications and all of that kind of thing. In particular, the banking and telecom industries, the ones that we've looked at the closest probably, as well as interoperability best practices in other countries. And for us, I think Denmark would still stand up as sort of the leader in terms of what they've done with regard to interoperability. Different size of country, different governance structure, et cetera. But you can't take anything away from them. They've done a bang-up job, and very clinician-led kind of process for interoperability. The key question, of course, is this the same as the US? Because the US, of course, is actually going through the same process as us. They're re-looking at interoperability, and because they haven't been satisfied with what they've done over the last 3 or 4 years. So is it like the US? Well, the short answer is yes and no. It's certainly like the US in terms of a focus on APIs, which if you read the US strategy, there's sort of 2 key elements to it. One is APIs, and that's a focus of ours as well. But unlike the US, we're not going to continue to focus on a single technical standard. I think as a country we've lived through that, and we don't want to live through that in the future. So whether it's V3, V2, CD, to be quite honest, we don't really care. So you'll probably see that as a slight difference in strategy between us and the US. And I guess at the end of the day, we'll both get judged on that. Is it possible that the approach is too clinician-centric? And I think there's another little twist in there. Is it too physician-centric? That one sort of made us step back a little bit, I guess. I think what we felt, it's very important that we focus the agenda over the next 2 or 3 years. And, certainly the focus is on clinical practice, so clinicians and their patients. We're certainly not excluding patients or consumers, but really the focus we'd like to have in the short term here is clinical practice. So we see clinicians, their patients, as the primary customer if you want, for interoperability, and actually the developer as the secondary customer, because those are the 2 kind of constituents that we're trying to support and help accelerate this agenda. So why focus on medication reconciliation? Well, we're not really focusing on medication reconciliation. We've just used that as an example here, just because it's easy for people to relate to. It's a simple clinical process. It involves a number of clinicians. It's not just physician, or it's not just pharmacist or nurse. It involves a number of people. And it actually plays well in terms of a specification, which can be reused for multiple purposes. Another question, what about process interoperability? This was a Catherine Hanna question, actually. So at one level, the standardization of processes may be required. That works well within a health organization. It's a little easier to pull off. It gets real tough across a province. It gets next to impossible among provinces. And we've seen, for people that have been involved in implementing drug information system, you've felt that pain. Trying to standardize processes, business processes across jurisdictions. And that has impacted certainly the pace and I would suggest the pain of interoperability in the medication space. However, at another level, process interoperability sort of translates itself into workflow. And remember, the good user experience speaks not just to access to content, but minimal disruption in workflow. So I'd suggest that certainly this agenda is certainly about workflow and clinician workflow. So what about standardization? And I think I've tried to communicate today. There is room for standardization, but let's focus on the data side. If we can get data standardization, those assets can be reused, and that's really that's the content that clinicians are looking for. On the technical side of things, maybe let's just worry about harmonizing. We're not going to have 100 different technical standards, but at least get it down to a couple, and no need to standardize on one. So that gives a lot more flexibility in terms of how interoperability can be done. Oh, and by the way, it's how interoperability has been done over the last 15, 20 years. we've got a number of standards in play, we've got new standards coming, and that will never change. There will always be a turnover of new standards in terms of what's going to be used, certainly at a technical level. So let's not fuss on it. So what does this mean for you? Well, there's an opportunity for us to sort of reinvent and move this agenda forward in a slightly different way than what we've done in the past, reinvigorate it. There's an opportunity for everyone to be involved as part in collaborating, being part of communities, etc. Let your voice be heard. Certainly from our perspective, we would like to see clinical requirements, specifications, and tools be embraced. If you're doing work, to share that and reuse the work of others, and obviously achieve the end goal of accelerating clinical interoperability. And where can you learn more about this? Just like I've been saying, go to the session tomorrow, 9 a.m. You will see all of this in a lot more detail than I can certainly explain to you today. And I think the detail that you'll start to see, and you'll get a feel for the interoperability platform, the clinical requirements, the specifications. I know the people that we've shown it to thus far have been quite excited about it. So hopefully you'll come to the session tomorrow morning, and look forward to seeing you there. Thank you very much.